all medical fraternity and physicians and other people, they used to believe that atherosclerosis is as a result of accumulation of the lipids in the intimal layer of the vessel wall. Now, this was considered that this is a lipid storage disease. As the time went on, one researchers, great academician and a cardiologist, Dr. Goran Hunsun, in 1980, he found out that in spite of correcting the lipids abnormality, there is no reduction considerably in the cardiac events. And the overall mortality and morbidity does not decrease if you correct only the lipids. So the search went on. What is something new? And that is a chronic low-grade inflammation of the arterial wall. As I attended the last 2 weeks before at Lucknow, National Conference on Diabetes, one cardiologist and diabetologist pointed out very correctly that the atherosclerosis is a process of a combined one, chronic inflammation plus dyslipidemia. So it's a jugalbandi. One cannot survive without each other. And this is the background of the atherosclerotic process. Up till now, we were thinking only of the lipids, but now we have to think about the chronic inflammation. To give you a little idea, in general, globally, this cardiovascular disorders, the leading cause of death in nearly 31%. In India, the situation is different. And less than 40 years of young people, they develop 12% to 18% of the coronary artery disease. To give you the little outline of the risk factors which we all have know. This is just for you people, it may be a recapitulation. The diabetes is number 1 risk factor, lipids abnormality is another one, the hypertension third one, homeostatic and thrombotic fourth one, behavioral is a stress factor, inflammatory process, demographic and genetic. These are the conventional risk factors. And the smoking, of course, another risk factor. I remember a person, Dr. Salim Yusuf. He's a great cardiologist in Africa. He has pointed out there are 250 risk factors for a coronary artery disease risk factors. It is not possible to correct each and every risk factor. So there is always some lacuna remains to control the risk factor problem. As we all know, the higher the risk factor score, higher the rate of complication. But it is not so every time. 60% of those who develop coronary events, there is only a one risk factor sometimes, and sometimes there is none. So this is a variability in the field of medicine. Similarly, more than half, either they were normal lipid profile or they have got abnormal values. Now today's topic is what is the role of inflammation in the process of atherosclerosis. As you know, if you recollect anatomy, when the vessel wall is there, there is the adventitia, media and the intima. The layer is the endothelium and there is a vessel lumen. Now in the blood, there is activated monocytes and the LDL component. Now LDL enters the inflammatory zone, converts into OX-LDL. Now this OX-LDL joins with the monocyte and produce a macrophage. This is a one cycle. Second cycle, as Dr. Rao has pointed out, the OX-LDL also the dendritic nucleus and produce another cycle. So in other words, the NF KB pathway and kynurenine pathway. These two pathways need not worry about this pharmacology advances, but if we tackle these two pathways with the therapeutic measures, certainly we can control the atherosclerotic process. As you all know, macrophages releases the inflammatory mediators like CRP, CD4D, TNF-alpha, IL-1, IL-6, etc. And the oxalate also affects the dendritic cells of the nucleus. So, in other words, in a process of atherosclerosis, the inflammation takes and the inflammatory mediators are released. Now, there are other etiological factors also. There is a chronic chlamydia pneumonia infection also produce some evidence of inflammation in the vessels. But this is in the experimental stage also. It's not 100% proof. There is some immune system also plays a role in this inflammatory process. But as we all know, we are staying in the era of evidence-based medicine. And we should have some concrete evidence that the inflammation has occurred. We know the lipid profile we do in many patients. But what is the evidence that inflammation has also occurred? So these are certain biomarkers. And these biomarkers are, number one, to measure a high sensitivity CRP. CRP we all know, but high sensitivity hsCRP is the investigation which tells us that inflammation is occurred. Second is the immunophenotyping peripheral blood monocyte measurement. And third is the immunoassay of the IL-16, IL-18, IL-15. Now these three tests are not being done in Jamnagar. I have inquired with the leading laboratories in Jamnagar, including Unipath and other places. They have to send blood to either Ahmedabad or Bombay to find out the values of this. And this tells us how far inflammatory process has occurred in addition to the lipid profile measurement. Now coming to therapy. We all are interested what therapeutic measures can be taken to control both lipids as well as the inflammation. We all know all the lipids are there, and to give you an idea about the therapeutic measures, the first and foremost thing comes in the mind is a physical exercise. Nobody can replace, in spite of many drug armamentarium devices and all these things of angioplasty, stent and bypass and all these things. But the role of physical therapy is extremely important for atherosclerotic process. How? We all know there are three types of physical exercise: aerobic component, flexibility component of all joints, and the third one is a spiritual one. Coming to the aerobic component, either a person who walks for 30-45 minutes, walking, or a running, or jogging, or cycling for 30-45 minutes, or swimming, dancing. These are the procedures for aerobic exercise. What happens during aerobic exercise? The muscle contracts, and muscle contracts, it releases the cytokines, and cytokines, they are very good anti-inflammatory agents. That is why the physical exercise has got a very good play a role to control this process. The second thing is we all know the current targets which we are using since long, all physicians world and everything, the statins controls the lipid abnormality. It also controls the high sensitivity CRP. So it has good effect on the anti-inflammatory also. Second thing, AC inhibitor, ARB. And third, antiplatelets and aspirin. These are the standard which we are using since long. The next three which I am telling you is thiazolidones. It is on the way of an investigation. TNF inhibitors, there is a phase 3 trials. And the methotrexate, which Dr. Rao has already pointed out about the rheumatoid arthritis, it also useful as an anti-inflammatory agent to control the CRP and IL-6. But these are the conventional which we are using since long. What is the new one which is useful to control this anti-inflammatory process? One is 3-HAA. I will tell you what is that. One drug is a kynurenine pathway, is a tryptophan. Tryptophan, as we all know, it is used for a depression, antidepressant, and for insomnia. This is also useful as in a kynurenine pathway, which I have mentioned. It is useful for the inflammatory process. The 3-hydroxyenthralic acid is a compound. For this, I sent one email to my nephew, who is a pharmacist in Canada for the last 20 years. He sent me nearly 50 references about the 3-HAA. It is a 3-hydroxyenthralic acid. It is a metabolite derived from the metabolism of tryptophan in the kynurenine pathway. Now, how it helps? It affects the macrophage and it inhibits all the pharmaceutical things which you need not worry. Nuclear factor Kb, nitric oxide synthesis, and interleukin, all these things. In other words, it inhibits the inflammatory process. It also plays an important role in immunoregulation. Now, this 3-HAA, this compound is not available in Indian market. Neither it is available in USA market or a Canadian market. The 3-HAA significantly changes the expression of lipid metabolism related genes. So basically corrects the lipid demand. How it affects? It reduces plasma cholesterol, plasma triglycerides, reduces the VLDL, increases the HDL, and significantly decreases the plasma lipids by 1/3 to 2/3 levels. It also affects the inflammatory process. How? It reduces the infiltration of CD4 cells in atherosclerotic lesions, and also affects the atherosclerotic process by a reduction in the atherosclerotic lesions. This is how 3-HAA works. To summarize, the 3-HAA is an intermediate product of the tryptophan metabolism. It has clinical significant benefits in atherosclerotic powerful inhibitors, and it reduces the lipids also and reduces vascular inflammation. Another drug, curcumin, Dr. Rao has already pointed out very extensively, and I will not give you more details about this. But as you know, turmeric haldar is a very popular among all people, and we allopathic people never used to consider this molecule, but now, as he has rightly pointed out, in rheumatoid arthritis and thing, similarly here also curcumin also helps, dosage and everything he has mentioned. But apart from curcumin, haldar, turmeric, it has got a pleiotropic effect. What are they? It decreases C-reactive protein, it significantly reduces the serum cholesterol level, improves the left ventricular diastolic function. So we can imagine how haldar helps us in cardiac problem. It prevents the progression of diabetic nephropathy and decreases fasting blood sugar. Other promising therapy are also coming in the way of the anti-inflammatory, and they are immunomodulatory and immunosuppressive molecules like cyclosporine and colchicine. They are under the experimental stage. Methotrexate, he has already pointed out. There are 3 trials, Thetis trial, CRT trial, and Kento study. They are all examined. The methotrexate is useful thing. I think the future generation of physicians, they will start using this newer and newer interesting. The blockage of other potential targets such as IL-6 receptor blocker and CD20 blocker also brings in benefits of the coronary artery disease. To conclude, despite our optimum therapy with current drugs, which I told you about the conventional drugs and the new one drugs is the 3-HAA and the curcumin. The 1/3 of the low risk individuals, they are known to develop asymptomatic cardiovascular problems. Tackling inflammation provides the potential to improve the cardiovascular outcomes, and some molecules targeting inflammation are being developed to provide a unique addition to cardiovascular armamentarium. And to summarize and give you what is the take-home message, that we were all thinking that atherosclerosis is a process of a lipid accumulation disease. It is not so. Now it is a combined one, chronic inflammation of the vessel wall, plus there is a dyslipidemia. Secondly, I already told you about the two pathways, how it occurs with the help of the OX-LDL. And I already told you the role of physical exercise should not be underestimated in spite of all this drug armamentarium and devices and all these things. And fourthly, newer and newer molecules will come in the market, as 3-HA will come in the market with a generic name also. And curcumin is also have a very potential role. And the new agents which I have told you. Thank you very much for patient hearing.